This is a presentation on the basics of geriatric hip fracture surgical management. We'll go through some cases in a brief survey. This is done by Alex Garcia and Devin Pekas, research fellows at Virginia Tech Carilion Clinic. And this PowerPoint presentation was originally created and presented by Dr. Seaman for the residency program at Virginia Tech Carilion Clinic. Geriatric hip fractures are currently a big problem and are increasing as the population continues to age. The rate of geriatric hip fractures is expected to double by 2050. These fractures are associated with a high mortality rate, and the surgical management of these fractures is critical for all orthopedic surgeons, regardless of specialty, as this is a fracture that everyone can expect to fix in practice. We're going to start with reviewing some background of femoral neck fractures and then go into reviewing some cases. The Garden classification is a descriptive classification of femoral neck fractures and is also used to guide treatment. Typically, type 1 and 2 fractures, which are non-displaced, are fixed with closed reduction and percutaneous pinning, whereas type 3 and 4 are displaced and are fixed with hemi or total arthroplasty, depending on activity level. There is an increasing trend towards arthroplasty for most geriatric fractures, but due to limited evidence, this is still a judgment call, as there's a high failure rate in patients over 80 years old. Femoral neck fractures can also be classified with Powell's classification, which is more often used for young people. Although this classification does not guide treatment, it can be helpful in analyzing the fracture based on the angle of impaction. A higher type Powell fracture is more vertical and can, in theory, benefit from fixed angle support or horizontal screws. Here's a case at Carilion Clinic of a 96-year-old male after a ground level fall. This patient has a left complete displaced fracture or Garden type 4 and needs to undergo hemi or total arthroplasty based on his activity level. In this next slide, you can see postoperative x-ray showing a well-fixed cemented hemiarthroplasty. Next is a case of a 75-year-old female after a ground level fall with a right valgus impacted femoral neck fracture. This is a Garden 1 fracture and can be fixed with the closed reduction and percutaneous pinning. Here's a lateral of that same fracture. These post-op x-rays demonstrate the inverted triangle placement of the screws, and if you look at the tip of the screw to the apex of the femoral head, it's important to have this distance less than 25 millimeters to eliminate screw cutout. And we'll go into more detail on this later in the slideshow. For geriatric patients with displaced femoral neck fractures, specifically those classified as Garden 3 and 4, cemented hemiarthroplasty is considered the gold standard. This approach is favored due to its lower fracture risk and lower reoperation rates when compared to press-fit options. One key point is the high failure rate associated with internal fixation in this population, which makes arthroplasty a more reliable option. Studies have shown that there isn't a significant difference in outcomes between bipolar and unipolar heads, and with unipolar heads tending to be less expensive, this can be a consideration depending on the patient's situation. Total hip replacement is another option, though it comes with a higher initial complication rate. The literature indicates that total hip replacement offers better functional outcomes, but this procedure should be reserved for more active patients who have normal cognitive function. When managing patients with Garden 1 or 2 fractures, the approach to treatment can vary based on the patient's age and the specific characteristics of the fracture. For patients under the age of 80, in situ screw fixation is an acceptable option, provided there is no significant displacement in the lateral plane. This approach allows for a less invasive procedure while still offering effective stabilization of the fracture. However, for patients over 80 years old, there should be a strong consideration for hemiarthroplasty due to higher rates of failure observed with screw fixation. It's also crucial to carefully scrutinize the lateral view on imaging, as many valgus impacted fractures are actually displaced into an apex anterior angulation. These fractures tend to perform poorly with pinning, so ensuring there is no significant displacement before surgery is key to selecting the appropriate treatment. Looking deeper at hip pinning, this treatment option remains viable and is specifically reserved for valgus impacted fractures due to their stable pattern and the benefit of using a less invasive surgical technique. Screws are placed in an inverted triangle screw configuration with one screw placed inferiorly, one anterior superior screw, and one posterior superior screw. 7.3 millimeter cannulated screws are most often used. As previously mentioned, it's crucial to examine the lateral x-ray to ensure no axial plane displacement, and the head fragment must be large enough to secure adequate fixation. In order to prioritize screw fixation, At least a 32 millimeter screw length should be used, and washers aren't necessary for this fixation. The next topic in our slideshow is geriatric intertrochanteric proximal femur fractures. These fractures present their own set of challenges and require different fixation, and we'll start with a few examples of radiographs of intertrochanteric fractures. The first example is the case of an 86-year-old female after a ground level fall that sustained a left intertrochanteric femur fracture. The fracture was aligned using a reduction finger tool and fixed with full-length intramedullary rod seen here. Next case is a 74-year-old male with a right-sided fracture after ground level fall. As you can see, the fracture extends from the greater trochanter and the lesser trochanter is very displaced. The next fracture is a 77-year-old male after a fall, which demonstrates an intertrochanteric fracture of his right hip. This patient was treated using a short nail, which is appropriate for fractures that are confined to the intertrochanteric region and do not extend into the subtroch area. Here's another example of an intertroch fracture. This patient, a 74-year-old female with ground level fall, and this fracture is more vertically displaced, and this was fixed with a sliding hip screw due to the more stable fracture pattern. We'll discuss the sliding hip screw in more detail in the following slides. The two treatment options for these intertrochanteric fractures are the sliding hip screw and the cephalomedullary nail, also known as the intramedullary nail. We will start with the sliding hip screw, which consists of a compression screw and slide plate that allows the compression screw to slide through a barrel at the top of the plate, and is a well-established method for treating intertrochanteric femur fractures. Despite the newer technologies, the sliding hip screw remains a traditional and widely used treatment option. However, it's important to note that this method requires an open incision for placement, which can be more invasive compared to other techniques. In terms of effectiveness, the sliding hip screw is generally considered equivalent to the intramedullary nail for managing most intertrochanteric fractures. However, one of the drawbacks is the higher risk of fixation loss and unstable fracture patterns. For cases involving unstable patterns, the addition of a trochanteric stabilization plate can help extend this indication for using the sliding hip screw by providing additional support and stability. While the screw remains a viable option, especially in stable fracture patterns, its use in unstable patterns often necessitates this additional trochanteric plate. Cephalomedullary nails are intramedullary implants inserted into the femur through the greater trochanter or piriformis fossa. They provide a strong proximal fixation into the femoral head and neck, with an option for distal fixation in the femoral diaphysis or metaphysis. These nails offer a shorter lever arm across the femoral head and neck screw, and they also offer the benefit of a medial buttress in its design, which helps prevent excessive fracture collapse, which is key for ensuring stable healing and can be inserted percutaneously, making it less invasive and time efficient. Depending on the fracture pattern, short, intermediate, and long nails can be used. When we talk about fracture pattern stability, there's a handful of characteristics that you want to look for. One of these is lateral wall integrity. The fracture is unstable if there's poor lateral wall integrity or there's lateral wall blowout. Reverse obliquity is another aspect. Reverse oblique patterns or transverse fracture patterns are inherently unstable. And then finally, you want to look where the fracture line extends. If it's greater than 2 to 3 centimeters distal to the lesser trochanter, this fracture pattern is now unstable. Here's a picture to help visualize the important aspects when evaluating bone quality in the intertrochanteric region. When we talk about the calcar, it's the strong cortical bone you can see better. In the picture on the top right, this runs through the two areas of cancellous bone around it. The calcar can still be intact even with a lesser trochanteric piece of Volst, so these fractures will still have plenty of cortex in the calcar to help support reduction in patterns with posterior-medial comminution, assuming it is not excessive enough to make the fracture unstable in some of the ways we talked about on the previous slide. This slide highlights the treatment of sliding hip screw versus IM nail based on the stability of the fracture pattern. The top fracture pattern shows in intertrochanteric fracture without any unstable characteristics. There's no comminution, there's no lateral blowout. It's a stable fracture pattern and can be fixed with either a sliding hip screw or nail. The second fracture pattern has variable stability. In all of these fractures, you can see the lesser trochanteric pieces of Volst, and in the second and third fractures, the calcar may be disrupted, so a sliding hip screw with a trochanteric plate or a short IM nail can be used. There have been many studies, including prospective randomized trials, to compare sliding hip screws with IM nails, and the overall consensus shows that there's no difference in overall outcomes for stable fracture patterns, whereas unstable fracture patterns like those we reviewed in the last slide will likely do better with an IM nail. There's not as much of a consensus on patterns with significant posterior medial comminution with an intact lateral wall, as the two fixation constructs have been shown to be equivalent. As mentioned previously, IM nails possess the advantages of a faster surgical time for short nails. It works for essentially all fracture patterns, and the enhanced biomechanics in terms of the medial buttress, which reduces the collapse potential, as well as it is less invasive. This brings us to our next point of why we would use a sliding hip screw. Technically, they're easier than a nail for stable fracture patterns, and they have less chance of a loss of reduction. They also have the same outcomes with less cost for stable fracture patterns. However, this is dependent on individual institutional factors. And additionally, there's no risk of damage to the abductors when placing this hip screw. So additionally, for IM nails, entry point can be very difficult to obtain. The starting point in patient anatomy is highly variable, and a bad start point can force malreduction. Additionally, the nail needs two guide wires to get in the perfect position, and rotating the nail in the femoral shaft can cause a loss of reduction if it's fit tight enough to rotate the femur as you rotate the nail. The sliding hip screws only require one wire for placement in the perfect position, and it's placed center sitter. Additionally, with sliding hip screws, you have less traffic around the fracture site when placing the hip screw, and the reduction aids are easy to keep out of the way. When you're using a nail and you have the targeting guide, it can be very difficult to use the bone hook and ball and spikes to reduce the fracture while placing the nail. It's also easier to control the proximal fragment rotation in left-sided fractures with the sliding hip screw. When placing the IM nail and screwing in the lag screw, this can result in malreduction of the proximal fragment seen in these radiographs. IM nails can also be harder to use due to often necessitating the use of a freehand technique. This can be extremely difficult as you have to miss the nail and avoid the guide when you're placing the pin to prevent rotation. Sliding hip screws, on the other hand, are much easier in this aspect. You can easily place a parallel anti-rotation wire superior to your working area, and it's easy to place multiple wires if you need to. Sliding hip screws also, as mentioned earlier, don't risk damaging the abductors with their exposure. IM nails, on the other hand, can risk damage to the abductors through the entry point, as well as through placing the distal interlock screw, which requires cutting through the vastus lateralis muscle. One major pitfall with sliding hip screws is lateral femoral wall fractures. These fractures are associated with high risk of failure when a trochanteric stabilization plate is not used. The uncontrolled compression when using the sliding hip screw can cause the femoral shaft to displace medially, and an example of this is seen on the radiograph here. In order to prevent this problem for lateral wall fractures, the trochanteric stabilization plate can be used. The main disadvantage of this is that you need an extended incision both proximally and distally. Some key technical points for both implants are, first of all, the reduction is the most important aspect in fixation with either construct. No implant can compensate for a poor reduction. The treatment and results are mechanically determined. The tip to apex distance under 25 millimeters significantly reduces lag screw cutout risk. And finally, if utilizing a sliding hip screw in the context of any lateral wall involvement, make sure to utilize a trochanteric stabilization plate. So overall, with geriatric intertrochanteric fractures, the stable intertrochanteric fractures can be treated with sliding hip screws or a cephalomedullary nail. The intramedullary nails are more technically difficult implants, but they offer the advantage of a smaller incision and biomechanical superiority, which is especially important for unstable fracture patterns. And it's important to consider all these factors when you're making your choice based on the individual patient as well as your skill level as a surgeon. In conclusion, some of the major points we brought up in this talk are that hip fractures are very common orthopedic injuries. Current implants and techniques continue to improve. It is vital for all orthopedic surgeons, regardless of subspecialty, to be able to diagnose and treat hip fractures. Regarding geriatric femoral neck fractures, cemented hemiarthroplasty is the gold standard. And for geriatric intertrochanteric fractures, utilizing intramedullary nail or sliding hip screw is best with intramedullary nail being preferred for highly unstable patterns. Thank you for your attention. Again, this was presented by Alex Garcia and Devin Pekas, Research Fellows at Virginia Tech Carilion Clinic. And this talk was originally created and presented by Dr. Jesse Seaman, who is Program Director at the Orthopedic Surgery Residency Program at Virginia Tech Carilion Clinic.